Good evening, everybody, and welcome to everybody watching on Periscope. We know there'll be thousands of you tonight. We can't, of course, have these fabulous evenings unless we have some help from our sponsors, so it'd be nice to say thank you, I think, to Intercert, who are here tonight, and MAXIMS, of course, and here from MAXIMS is Michael, who always wants to come and say a few words of introduction to the
Now you can go.
Okay, now. Well, but not tonight. So.
Tough. It's really good to see lots of old friends here.
So friends of long standing.
Obviously, we all enjoy returning for this sort of habitual ritual verbal abuse from Roy Lilley, but we'll get used to it, don't we? And from my point of view, it's a real pleasure to welcome our guest, Professor Sir Michael Richards, because you will hear undoubtedly from Roy all the things that he's been able to do on behalf of the NHS, and they are really, truly wonderful. From my point of view, he was one of the czars when I was working in the Department of Health, and my particular preoccupation at the time was information systems for health.
We finished at half seven.
As indeed nine. Natalie, stand beside him, drag him off. And Mike was the only czar who had the courage to put electronic patient records in his strategy, and I think now he's got plenty of reason to be proud of that, or pleased that he did it, so we look forward to hearing more.
Let's give Michael the clap he so richly deserves. Not so sure about that, are you? Right, okay. Ladies and gentlemen, let's welcome our guest, Professor Sir Mike. Right, have a seat. Make yourself comfortable. Also, we should also mention that our good friend Roger Klein is not very well. He's probably watching. Is he watching?
He's already sent a question
via
Twitter.
Okay. And Roger, we hope that you get well soon and you're not too much of a drain on resources.
And by the way, Roger, there's a card coming from Roy and myself.
Yeah,
it's on its way.
Drawn him again. And our front of house sponsors, Sarah, she's watching as well. She's got a frozen shoulder, so we're sorry about that. And we wish you well. Apparently, she tried to reach into her handbag to buy a round of drinks, and she's done. It's nice to know that she's on the mend. Right. Well, listen. Thank you very much for coming. I can't stand the CQC. I think you're destroying the health service, but we'll get to that later on. Why? We always like to know a little bit about our guests. Why medicine?
Well, actually, originally I planned to study physics. I went to university.
What a
to
shame
physics.
you didn't.
No, best decision I've made in my life. After a year there, I thought again, and I went down the list of everything that you could study. I come from a medical family. I don't know why I hadn't thought of it before, but I really hadn't. And I have been glad ever since then that I changed to medicine.
So, yeah, where did you train?
I trained...
Because you went to, was it Oxford?
Cambridge, and then Barts, and then Barts did my oncology training there, and then ended up as a consultant at Guy's, and then Guy's and St Thomas's.
So you were a junior doctor?
I was indeed a junior doctor.
What do you think of these lazy junior doctors that are on strike now then?
I do not think that they are lazy. Let's make that very clear. I think they are clearly very unhappy at the moment, and I think we need to understand why they are unhappy. And really get behind that, to what extent it is about money, but to what extent it is about the working life.
Yeah. Well, it is. It seems to me they've become the lightning conductor of everybody who's got any kind of a complaint about the current NHS, and heaven knows there's enough to complain about. But they can't seem to kind of crystallise what the issues are. They would get, it's not safe and it's not fair. But what isn't safe and what isn't fair?
Well, I think at the moment they don't feel valued in the way that when I was a junior doctor I did feel valued. We worked very, very long hours in those
But you were doing 120 hours, weren't you?
I was, but it was as part of a team. There was camaraderie, there was continuity of care, you were looking after the same patients, you knew who was who. And yes, we lived in the hospital most of the time, but we thoroughly enjoyed it. And I think that has been lost, and I think we've got to find ways of getting back to that.
Because they don't have firms quite like they used to, do they?
Not in the same way. I shadowed one of the junior doctors who worked with me about 3 years ago, and it was on a bank holiday, but the registrar, the FY2, the FY1 and the consultant had never worked together as a foursome before. They didn't know each other, and it took half the day to sort of find out who was who.
Yeah. So maybe the solution lies really outside the contract and more in how their day is organised or their teams are organised.
I think we've got to look again at that. We've got to look at what are the sources of stress and satisfaction for junior doctors. I did some research many years ago when I was at Guy's on stress and satisfaction in consultants. I think we now need to do the same sort of thing, but specifically focusing on the junior doctors.
How do you see it? I'm running because I don't know what's going on any more than anybody else does, but I mean, I hear no gossip or anything that are even talks about talks, or no one's in the same room. We just seem to be going headlong into it over the cliff.
And somehow we've got to break through that. I know that Sue Bailey at the Academy of Medical Royal Colleges was asked to look at those other things that weren't the money, if you like. But I understand that the BMA have declined to participate in that. I think that's a great shame.
Looking at the Dalton letter, which is the last document that was published on it, and it's, I mean, it's I don't want to say one side or the other. Really, they've got to sort themselves out. But it was hard to see where else the employer could go. They've pretty much surrendered the idea that Saturday would be a different day. I mean, half of that's gone back to the way it was. I mean, one wonders really where we will end up, because in the longer run, it does have a big impact on how hospitals are run and the quality of the services.
Absolutely. I mean, junior doctors are at the heart of our services, and in terms of CQC, we always speak to the junior doctors when we go into a hospital. We often have junior doctors on our inspection teams, and very often the junior doctors are the ones that can really tell us what is going on in the hospital, because A, they move across the whole hospital, so that between them they see the whole hospital, and B, they've worked in other hospitals recently, and they can make those mental comparisons very easily.
Yeah. Anyway, so I don't know why we got sidetracked there, but just wind the clock back. So let's go into why cancer. What was the interest for you in cancer? Because you got into it at a time when we knew almost nothing about cancer, didn't we?
And certainly we were doing very little to invest in cancer or cancer doctors in this country. When I was at Barts, there was a hugely charismatic doctor, Gordon Hamilton Fairley, who very sadly was blown up by an IRA bomb. It wasn't designed for him, but his dog looked under a car and the car bomb went off. And I had been lucky enough to see him at work, and I think that was the start of my thought. He enthused us all that actually there were things that could be done about cancer, and that we shouldn't just give up and say this is a dreadful disease, nothing can be done. And he really started a fantastic unit at Barts, which still continues. And so then I went back to Barts after I'd done my junior jobs to train as an oncology fellow.
I'm kind of totally confused by where we are with cancer. I mean, I was reading the NLE report that was out today, I think, where we've gone from 64% recovery in the first year up now to 74% survival rate in the first year, and that's over quite a long period, isn't it? 10 years, I think it is. And the 5-year survival rates, we don't compare very well with 5-year survival rates. What is wrong? What do we do? Well, I've got two questions really. Who does cancer the best, and where are we in that?
Well, when I was doing the National Cancer Director job, one of the projects that I set up and I then chaired was an international cancer benchmarking group, and that involved people from Australia, from Canada, Norway, Sweden and Denmark, as well as 3 of the 4 countries in the UK, in order that we could compare in detail what was going on, because we've got the cancer registry data that, as you say, we're saying our 1-year survival is particularly poor, or 5-year survival. If you live to 1 year in this country, your 5-year survival is roughly speaking the same as it would be anywhere else. But the real problem is those early deaths. And we did a number of different studies in this country. Do people know as much about cancer? Are they as aware of it as in other
When you say
countries?
people, you mean the
People, the
public, yeah.
Broadly speaking, we did the same survey in all 6 countries, and broadly speaking, levels of awareness were the same. Interestingly, people in this country didn't want to burden their GP. That was one big difference, and so they were more reluctant to worry the GP or to waste the GP's time. That was one part of it, and certainly we did another study looking at GPs and asking them questions, giving them little vignettes of what would you do in the following circumstances. And in England, Wales and Northern Ireland, which was the 3 countries from the UK participating, we had a much lower propensity to investigate or refer than in other countries.
Is that a GP thing? Because I remember reading somewhere that the chances of a GP seeing a cancer in the course of his career was, I mean, the numbers are desperately low. You know, you only likely to see 5 cancers in your career. Or
No, it's about 8 cancers a year
8 cancers,
that an average GP will see. But on average, one of those will be breast cancer, one will be colorectal cancer, one will be prostate cancer, one will be lung cancer, give or take. And then there are a whole lot of other cancers, which between them they will see 4 in a year. So it is difficult. They may see a brain tumour only once in 10 years or whatever it is. So I'm not saying it is easy, but I don't think we have made it easy enough for GPs to get access to diagnostics.
Well, what is that all it is, or I mean,
where
do they do it well, Mike? I mean, where's the best place to have cancer?
There are pros and cons in different places, but I think we were really comparing ourselves with Australia and Canada, and we chose those countries because they have good data, and we wanted to be able to compare ourselves with good data. B, they were countries of roughly speaking similar wealth to ours, all with universal health care. So we were comparing like with like in that way, and certainly Australia or Sweden or Canada on all of these things came out better than the other countries. Funnily enough, Denmark looked remarkably similar to the UK in that respect.
Right, and is that because we don't present early enough?
Yes, I think it's
early blue-collar malfunction.
It's early diagnosis, which is a combination of patients not seeking help and also of GPs not being encouraged to investigate.
Yeah, I did some stuff with colorectal cancer, and I was horrified to find that the way you find out about it is you go poking about down the Kazi with a spoon. It's just Neanderthal.
Well, yes, and that's why we have a bowel cancer screening program, which is not quite that. But
all right. What is it then?
Well, actually, the new program is about flexible sigmoidoscopy, which is a one-off, let's say at the age of 55 to 60, and if you're clear,
everybody should have.
That would be my recommender.
But the NHS always resolves, doesn't it, from screening? You
actually,
that
no
woman in
one's screening.
Scotland, Margaret MacDonald, is it, who says we over-screen?
Yes, she does, Margaret McCartney.
I'm terrified to ever mention screening anything I write, because she always emails me and says, you're wrong.
But actually, if you take colorectal cancer, it is one where all the studies point in the same direction, that there is no difference at all as far as I can see. Screening by whatever method saves lives.
Right, and why don't we do more of it then?
Well, we are doing.
Well, you were the cancer czar.
And I was indeed. Well, I helped to introduce some of these programs, which I'm rather proud of. But we need to get the uptake higher, and this has now been taken on by Public Health England, and that's great. And we need to make sure that people actually do understand that screening can save lives. Because the thing about, particularly with bowel cancer, if you find it at the polyp stage, this is before it's become a cancer, you can remove it and you then prevent a cancer. You're not just diagnosing it early.
Perhaps you'd avoid being too graphic. I'll find some of this.
I didn't think I was being terribly graphic. I could be a lot more graphic if you want.
Oh, please.
But I mean, if you look, I mean, Public Health England, talking of colorectal cancer, they've been stuffed up the back passage of the town hall and disappeared, haven't they, really? I mean, well, on the one hand, you've got Simon Stevens today wanting to take over the National Trust and rebuild Britain with grass verges and seats for your granny. And on the other hand, you know, you've got Public Health England has just completely bloody disappeared. And they do everything from pork and down to pork sausages. You know, how the hell can, where does it, they're too big and sprawling, aren't they?
Well, I'm not going to comment on Public Health England. I don't work with them or for them particularly closely at the moment. But what I do know is that if we don't get on top of the prevention and early diagnosis agenda across a whole range of different conditions, we are not going to have the healthy long lives that we should have.
I agree with that. I just don't see how we're going to do it. I mean, it seems to me that we could do more through employers. We could incentivise employers to push their staff towards screening.
And one of the employers that we should focus on is one of the biggest employers. It's called the NHS.
Yes.
And I don't think we have done enough. And Simon would agree with this. And I think we do need to incentivize.
He's busy taking over the National Trust.
Well, he can do both. You know, he's quite capable. But we do need to make sure that we look after our own workforce. We've got a workforce of 1.3 million.
We can't even agree to paying conditions with 55,000 of them. Don't tell me about looking after our staff.
Well, I do tell you
We've
about
just
that.
pissed off the backbone of the NHS with their contract.
So let's try and keep everybody healthy, not just the junior doctors, but they are important too, but everybody else as well.
The nurses will be next.
Well, interestingly, I went to a degree ceremony at the University of Hertfordshire a few years ago, and what was very clear, watching people coming up to receive their degrees, was what the body mass index was of different groups of health staff.
Oh, you're going to get into terrible trouble here.
Yes.
Go on.
Suggesting nurses are fat.
I didn't say which group.
Why you followed on from the comment about nurses? I think you need to clarify that.
The people on Periscope is a very skinny blonde bird sitting in the front.
What I am saying is we should take notice of the health of our workforce, and we should help them to live healthier lives.
Yeah, I mean, joking aside, I mean, it does seem to me that Public Health England is just a great big sprawling organisation with Duncan Selby sitting on the top wondering what happened this week. And if we were really interested in being able to do something with screening, we should say, okay, we'll adjust the national insurance contributions of employers who promote screening.
Well, actually, I think one of the things about national screening programmes is that they are by far the most effective way of getting screening, and our coverage with screening, in other words, the proportion of people in the relevant age groups to go for screening, is actually high. We come out well on screening.
But we don't come out well on outcomes of cancer.
No, because, and there's a reason for that, Roy, which is that there are, at the moment, only a very small number of cancers for which we have effective screening. So, cervical cancer, bowel cancer, breast cancer. So if you look at all the people who get diagnosed with cancer, it's only about 5% of those who are diagnosed through screening, because we don't have effective screening for lung cancer.
Well, what is Margaret McCartney's argument about not doing screening, the false positive argument?
The argument there is about early diagnosis, and Margaret McCartney firmly believes in that. One of the things that we did while I was a National Cancer Director was set up a panel. I did this jointly with Cancer Research UK. Set up a panel to review all the evidence about breast cancer screening, because that's the one that's most controversial. And it was led by Michael Marmot, who is a very good man, and he had a very good panel looking at this, and they came out saying, yes, there is a degree of overdiagnosis, but there is also, there are lives being saved through screening, and what matters then is to present those facts in an open way to the public so they can make their own decisions. And we did a lot of work with David Spiegelhalter at Cambridge about how you can best present these complex numbers, but how you can do that simply.
Part of the solution must be to look at the target audience for certain types of cancer and promote screening to them.
Yes, and the easiest way of doing that is by defining the age range, because most cancers are uncommon before the age.
But the GPs have got to do that, haven't they?
Well, and one of the things that we also worked on was giving GPs the tools, the electronic tools, to help them work out what the percentage chance of somebody having cancer is based on the symptoms they're coming with, their age, maybe their smoking status, whatever it is. And there are now those electronic tools to help GPs. And basically the nice guidance is that if you've got a 3% chance of cancer or higher, based on that, you should be investigated or referred.
Yeah, but I don't see the connection between identifying people with superior data and superior tools, which have really only come around in the last 5 years, and the connection with the target audience and getting people to do it.
Well, and
what do
that's
they do in other countries? My first
well,
response to any problem we've got in this country is what do they do elsewhere?
I think that's a very logical first response. What I'm saying is, on the screening side, we compare very favourably with other countries. On the diagnosis of people with symptoms, who are the much larger group, that's where we do poorly, and it's partly, I think, people's reluctance to bother the GP. It's partly the reluctance of GPs or the pressure put on GPs.
You can never get a GP, can you?
Not to investigate.
Ring them up between
that's what we've got to
8:27 and 8:31 and keep your fingers crossed. Get it on speed dial. You can't get in, can you?
It's really interesting. That's not what the surveys say, but you know, it is what
I never see my GP. My GP surgery is closed when I go to work. It's closed when I come home. It's closed. Well, if the Saturdays it's for an emergency, and I'll go and do A&E, see a proper doctor. I'm going to bugger about the GP. And then on Sunday, I go to church and sprinkle myself with holy water and pray for a cure because they're closed. I never see the lights on.
And that's why we have a government that is in favour of 7-day services.
Oh, really? Well, let's talk about that. I'll tell you what, that's a good answer. I think I'm going to let that one settle and then people make their own minds up about that. No, I mean, you can't, I don't know. Just seem to, what about a separate screening service? Maybe we take it out of the hands of GPs.
Our screening is fine. It is our diagnosis.
But something's going wrong, isn't it? We don't have good cancer outcomes, but all the front end you say is fine. But
not all the front end. Screening, remember, is for people who haven't got symptoms. But people, when they've got symptoms and they go to GPs, that's where we're not doing well. And that's where I think we ought to have more sort of diagnostic services in the community, well organised. And I think this can absolutely be part of what Vanguards are doing.
So should we let the private sector do it? Why don't we let out a big national contract for cancer screening?
Well, remember, we have had private contracts. We had private contracts for MRI. We've had private contracts for PET-CT. I'm neutral about that. What I want to do is to make sure that we get good access to those diagnostic tests and that we get good value for money. As long as we have both of those, I'm happy.
No, I'm not
Isn't that Darcy?
Sorry?
Isn't that what Darcy was?
He was talking about that, wasn't he? What about you got? What's happened to the cancer networks? What's happened to them? I went to sleep and woke up one morning, they're gone. What's happened to them?
I think.
How much did we spend on that? Was that down to you?
Well, the cancer networks, I think, were a very effective mechanism.
Well, where are they?
I'm afraid that with all the changes that went on post-2010, they did get downgraded. I think there's no doubt about that. And I think that is a great shame because basically with cancer you need a whole range of people working together. You need the secondary care services providing diagnostics like endoscopy or MRI or CT, etc., and the initial biopsy. You may well need highly specialist surgery at a tertiary centre. You may need to go back and have radiotherapy and chemotherapy, and you want to have that relatively close to home. You need GPs, secondary care and tertiary care working together. That's what a network's all about. And that's why we set the networks up. And I think we will find ourselves reinventing them where they are not as active as they were.
Vertical integration.
That's exactly what they were, and this is what the first cancer plan of the year 2000 actively recommended. We said to the country, you have got to work out what your networks are going to be. It started with being 35 and it went down to 28. 28 always seems to be the answer in the end. But that was very effective in terms of getting the coordination.
Yeah, do you think that cancer report, I remember that coming out, do you think that was too early? Do you think now there's a greater awareness and public awareness of cancer?
No,
It needs another initiative.
Well, there have actually been a number of initiatives. So we've had the cancer plan of 2000. We've had the
What a wonderful piece that was. It made all we do is making shelf makers rich.
Not a bit. That plan really drove change. Yeah, I am absolutely sure it did.
Well, what did it change? Because we're still not good at cancer.
We are a lot better at cancer than we were. We are absolutely a lot better. We are narrowing the gaps, but we haven't eliminated it. And the part we haven't eliminated is the bit before that people get to hospital. That is the big problem area. So yes, what we set out to do in getting secondary and tertiary care working together, all of that has worked really surprisingly well. And I think we have then updated it in 2007, updated again in 2011, and now we've got the Cancer Task Force report that came out in 2015. But I think with all of with cancer, you're probably going to need roughly once every 5 years to be updating your strategy.
Interesting. Well, look, I suppose we're going to have to talk about the elephant in the room, aren't we? Let's could you just list for me the hospitals that you run?
I don't run any hospitals.
Have you never run a hospital?
I've been a member of the executive of a hospital, yes, a large hospital in London.
What did you do for them then?
I ran their cancer services, and I also.
It's not like running a hospital, though, is it?
No, but I wasn't running the hospital.
My point is, do you think we should put the responsibility for running hospitals properly in the hands of someone who's never run a hospital?
I'm not responsible for running a hospital. I'm responsible for assessing the quality of care that is given by hospitals, and I do think I know about that. I know about it from my days as a doctor. I know about it from my days running cancer services and running large peer review cancer programs to actually assess what the quality of cancer programs is. And now what I'm doing is extending that and saying let's look across a whole hospital and let's look at the quality of a whole range of different services within a hospital. And yes, but do I do that on my own? No, I don't. I get experts in different fields, whether that's in A&E or whether that's in medicine or surgery or maternity, to advise me. I'm not an expert in maternity at all, but I know people who are, and they can advise me on how we can best assess the quality of a maternity service.
See, I mean, the problem I think a lot of people have with inspection is, I mean, it starts with Edwards Deming, doesn't it, who said in his 14 points of management, which I'm sure is something you've never bothered with, but in his 14 points of management, number 3, he says, don't rely on inspection to improve quality. And then if you go on from there, you've got Charles Handy, you've got Tom Peters, you've got Heidsick, you've got every sort of person that's ever studied management will tell you that inspection is the last thing you want to do to improve quality. Why do you think that? Why do you swim against that tide? I mean, I could be.
Okay. Because I know that cancer peer review, which was a form of inspection, did improve.
But
cancer
peer
services.
review is, I'm not going to let you off with that.
No.
I mean, peer review is entirely different than turning up with charabancs full of people and clipboards and traipsing through a hospital.
Peer review also may not have been charabancs, they were smaller groups, but they were only looking at cancer
Smaller
services.
charabancs.
So they were.
Peer review, we all understand this is an educated audience here.
But actually, what we're doing now, Roy,
It's not
is
peer
a
review.
larger form. Yes, it is peer review, but it also has teeth.
No, you
because
write
we are
things along the
regulated.
lines of, I saw one the other day, one of our inspectors saw a drinking glass out of the reach of an elderly patient. Wow.
Yes, that's one thing. And did you read the other 200 pages of that report? I don't know. You may have done.
Yeah, I'm quite a student of your stuff, actually.
I'm delighted you are. But what you will then know is that we make judgments on hospitals by, first of all, gathering a whole lot of information together from national data sets, also asking the trusts themselves for information, asking the commissioners and others what they think of what's going on in the trust. We then do take in a relatively large team, but that then breaks down into teams of 4 or 5 who go to the A&E department.
There
and
are
alternative
hundreds of them. What does it
No,
cost? What does
no,
it
actually-
cost to inspect the average district general hospital?
About £150,000.
No, it's more than that.
No, it isn't.
It must be more than that.
No.
You can't do it for 150
We-
grand. And
well-
even if you did, it's too much.
Well, I can assure you that if you look at the costings of my part of CQC, including the strategy and intelligence people who are working with us and the call handlers and everybody else, put all that together, the costs of my programme are less than 0.1% of the turnover of these hospitals.
Then you look at the costs in flow around inspection. I mean, I was up. I'm not going to tell you which hospital I was at, but it's a very well-run hospital, and I was there. Terry and I were up there looking at this hospital, and they'd spent 200,000 getting ready.
Well, what if they had? That's up to them. I think this first time round, people will have spent a lot of time and effort getting ready, and actually, that's probably led to quite a lot of improvement. And there are a lot of trusts that will come back to us and say, yes, we did put things right during that time. It was a good exercise to go through. And we also know that it's the trusts themselves that tell us that the inspection process has helped them to improve. I can give you the figures. It's right here in front of me. Yeah, I'll tell you.
Oh, God, here we go.
I'm going to tell you.
Switch off.
I don't think if 80% of trusts say that inspection identified areas for improvement and helped 70% said actually helped them to improve.
Well, what do you think they're going to tell you? They're all terrified. They're not going to say the whole thing was a basket case.
These questions, we don't. It's anonymous feedback, so we don't necessarily.
They're all terrified that you're going to turn up and do it again. I mean, the whole thing seems. I mean,
No,
really.
not.
Do you remember when Sam Jones won the Chief Executive of the Year?
Yeah.
She sat in that seat and told us all about it. She was Chief Executive of the Year. The next morning, 6 o'clock in the morning, you turned up with 200 people to inspect her hospital.
Oh, we didn't turn up with 200 people. Let me be very clear about that. But
How many was it?
I would guess that would be about 50 of that trust. So you're only multiplying by 4, but there we go. That's about par for the course.
I've never known to underestimate.
No. So, and actually, that trust has long-standing major problems, and that's why.
But we all know that.
No, I don't think everybody did know.
I
No,
think
it's easy to say that with
the
hindsight.
local health economy is melting. The infrastructure looks like a bomb site.
I can tell you, lots of
she
people.
was struggling to recruit.
Yeah, and what I'm not saying is that was Sam's fault. I have talked to Sam at some length about it, as you can imagine. But I think there were long-standing problems. What she has said to me is she wishes that she had cried for more help sooner about that hospital, because it's really challenged and it needs
Well,
a
she
big
had.
turn.
I'm not going to go into the history of Watford, but she had the TDA all over her, and they were being most unhelpful. Let's put it like that. At least I'm accused of exaggerating.
But the whole point of the special measures programme is saying these trusts need external support.
Do you think special measures is the right phrase to motivate people in the hospital?
I think the phrase is obviously borrowed from education, but I don't think it matters what the phrase is. I think there is an initial shock from the trust, but quite often what we hear is people working in those trusts saying, thank God you've actually found out what's going on here, because now we can start to make the changes and now we can turn it round.
Do you think they should wait for that? I mean, shouldn't we?
No, of course they
shouldn't
should.
we focus on running our hospitals in a way where people do feel free to say there's something
Yeah,
wrong?
and absolutely.
Don't you just drive it underground?
What we need to do is hopefully give people this framework that we've got, and people will have had this on their seats so that they'll know our framework. Our framework is that we ask 5 key questions about every service we go into. We've defined 8 core services that we always look at, and they were chosen because they're high volume and high risk. And so we rate them on these, and that's a framework that then trusts can use
But
themselves.
you're going to stop doing this now, aren't you?
I hope that in this next phase, very soon, by the end of June, we will have finished our first round of comprehensive inspections. And that will be a huge landmark. We will have a better picture of the quality of care in the NHS.
You'll have a picture of. Well, hang on, Mike. You'll have a picture of what you saw on that day. You won't have a picture of what the quality of the NHS is.
Okay, we can't get them all. You'd be even more worried if we were trying to go to all of them on the same day. But over a 2-year period.
But you'll have a snapshot of what a hospital was like on the 25th of October in 2011.
No, we only started rating from 2014. So this is 2014, 15, and into 2016.
But we've been inspecting hospitals for 16 years.
And we've never done it well before. And we are now doing it well.
What's the return on investment? I worked out that we'd spent £3 billion inspecting hospitals one way or the other. And, all right, perhaps I am sometimes prone to exaggeration, but I did do that carefully. So £3 billion inspecting hospitals, and still 2/3 of them, and according to you, are no good.
And Roy, going back to your point about does inspection deliver improvement, not on its own, but shining a spotlight helps trusts to know where they've got problems, and they don't all know where they've got problems, and then it's primarily for the
showing people what good looks like. You don't. You show them what bad looks like.
Ladies and gentlemen, on your seats, you may have this. I can show you what good looks like.
Then you show me what green looked like on a particular day. You can't show what good looks like. Is St Thomas's doing a good job tonight?
We are in the process of finalising our report on St Thomas's, so I can't comment on that.
But is it doing?
I can't comment on that one today. But I can comment that Frimley Park is doing a fantastic job.
Yes, and do you know why?
Because it's got fabulous leaders.
Yeah, and do you know why?
Well, it's got
the chief executive, Andrew Morris, was appointed 30 years ago by a very far-sighted, articulate, intelligent, good-looking chairman of the Health Authority. That modesty prevents me from telling you who it was.
He's even exaggerated the number of years ago, but there we
are.
It is but he's done a fabulous job.
Of course.
But with that,
I take all the credit.
You take the credit, but he's also then got around him clinicians who have stepped up to the plate to be good clinical leaders. He has no difficulty recruiting clinical directors. People at Frimley Park want to do that. And the proof of the pudding is in what they then did when they went into Wexham Park, which is also on your sheet, and you can see how red that is. And at Wexham Park, that's what it was like in 2014. And a year later, a year and 2 weeks after they had acquired Wexham Park, Frimley Park had changed it round. Now that is the most remarkable turnaround in the NHS that I'm aware of, and I would almost challenge anybody to say, can they find a better example? We went very carefully through the Wexham Park on both occasions, so we had some of the people were the same on our inspection team, some deliberately we chose people with fresh eyes. There was no doubt at all it's transformed. And it's not just us saying it.
Okay. I'm not going to assault you, it's all right.
All right.
I just need, I have a signal that I need to move the microphone.
Okay. But the people of Slough who are served by Wexham Park are getting a much better deal
okay,
now
so what's the worst hospital you've been in?
Well, there are 3 trusts that have been in special measures since Bruce Keogh, since Bruce Keogh inspected them in 2013 and are not yet out. North Cumbria needs reconfiguration. I think everybody agrees with that. Sherwood Forest is now about to be taken over by Nottingham, and I personally welcome that because Nottingham is providing good quality care, and I think I'm very hopeful that will lead to change. And then there are 2 others, Medway and Colchester, both of which are still in special measures. Medway now has a strong partnership with Guy's and St Thomas's, and I hope that will lead to turnaround. And we are watching Colchester extremely.
See, my question is really, what are you doing to introduce Colchester to Frimley Park? What are you doing to show them what good looks like?
Believe you me, I have had that conversation with the people at Colchester myself, and I have encouraged them to go and see. And not just Frimley Park, but other places that are doing a very good job. And part of what I think we can do at CQC is to point people to where there are either outstanding whole trusts or outstanding services, so that they can know where to go and look.
But I mean, I don't even know where to start with this. This is just like complete nonsense, it seems to me. I mean, we've got the monitor, right? Not what do we call it? Not monitor. What do they call it?
NHS improvement is what you're probably
right.
thinking of.
Okay, they're out there improving things. Well, where do you fit into all that? It seems that we've siloed improvement. I mean, if you're the one that stomps around with the clipboards finding things wrong, and you've got no real mechanism to put it right, other than perhaps say to Colchester, why don't you pop over to Frimley and see what they're doing? This whole transfer, I mean, I just don't understand what the mechanism is for diffusion of best practice.
Okay, so first of all, where we find things seriously wrong, we can impose conditions on that service, either to reduce the volume of work being done by that service because they simply can't cope with it in the short term. Ultimately, we could close the service, and you recognise in the NHS how difficult that is. We can issue warning notices saying they've got to put things right within, let's say, three months. So we've got a range of powers. That's why I said this is peer review with teeth.
But the powers that you've got, in all common sense, and in the practical nature of hospitals, where people often have very little choice about where they go, most of the powers you've got are useless. What can you really do? You could do what Andrea does in nursing homes and close them down, and then you get photographs of little old ladies wrapped in blankets being shuffled off at 6 o'clock at night in ambulances. That makes you look terrific. I mean, what can you do with a hospital? Well, you see, I reckon that you and I could look at a map of the NHS, and we could pretty much agree where the hospitals were that were having problems, because they're historical, overheating health economies. They don't have the right money, and they're prisoners of their own geography. I mean, look at the ones down on the coast, right? A lot of hospitals on the coast are having problems, right?
Yep.
So why do we need you to spend a fortune aggravating everybody to turn up with something we could actually spot on a map?
So what you might be surprised to hear is how many hospitals say to me, thank you for pointing things out to us, thank you because we will be able to use that to improve. And interestingly, that can be at any either end of the spectrum.
You made a very good point, because I was with, I can't tell you which hospital it is again because they get very embarrassed, but I was with a chief executive who said, oh, well, he said, I know you're against the CQC, Roy. He said, but they came and he said, and they found out lots of things that were wrong with this place. It was the best free consultancy we've ever had. And I said, right, if I was your chairman, I'd say you're fired, because it is your job to know if things are wrong with the organisation, not wait for Mike and his merry band to turn up in a bus.
And unfortunately, not everybody does know what's wrong, but even in some of the very good trusts, we find things that are not as good as they should be. We point them out to people. But you'll always find that,
wouldn't you? I could take you to Frimley Park and find things wrong.
Well, we did find one thing wrong.
And that made your day?
No, it didn't make my day at all. It didn't make my day.
What was it?
It happened to be in their services for children and young people. I'll bet that was put right within about half an hour.
Was it safeguarding?
It wasn't safeguarding, no. Because
that always catches everybody out.
Well, safeguarding can catch people out, but that wasn't what it was as far as I can remember that. But we
I shall ring Andrew later.
Well, I'll bet you any money you like that is now would be good if I went in tomorrow. But whether it's Frimley or whether it's Salford, or we find things in hospitals because they're not perfect. And we help them, therefore, to put it right because they've got the ability. Yes, we do, because they hadn't spotted these things. Quite recently, there was a chief executive came up to me at an NHS providers conference and said, "Mike, thank you for spotting a real problem on our critical care unit. We didn't know about it, but we now put it right." He should
have known about it. You should say to him, "Don't thank me. Just thank yourself lucky you've still got a job."
Yeah, but I mean, you may have been the most perfect chairman in the whole world. I'm sure you were. Of course you were. But unfortunately, we don't have those in every single hospital in the country. And so, actually, it is helpful to have someone external, independent. And remember, we are seeing the quality across the whole country. This is a job that actually I think CCGs find difficult because they haven't got the benchmarks.
How many trusts have you found problems with quality? We've only got one, haven't we, that's perfect, which is
we haven't got a single hospital that's perfect, and we probably never will have. And I will be very reluctant to say that. We have two trusts that have so far been rated as outstanding overall.
But that's not really outstanding. I mean, with fairness to Frimley Park, Frimley Park is run as it should be run.
Frimley Park and Salford Royal are both outstanding.
That's the blessed St David's Trust.
It is indeed.
Yes, where he walks on water and he's carried shoulder high to his desk by his adoring staff.
But he runs a damn good hospital.
He's been there a long time.
He's been there a long time.
Yeah.
But what I've shown with the Wexham Park example is that a good person, Andrew Morris, supported by good clinical staff, can turn a hospital round.
I don't think that's
just
exceptional. I don't think it's exceptional at all. I tell you why.
Well, you name me another one.
Well, no,
come on, Roy.
well,
you don't think it's exceptional?
No, but
come on.
But I can't, and that's my point, because it's the first time where we've had a pure, naked takeover. Previously, where we've had dodgy hospitals, we bodged them together and called it a merge, and they've had a fight over who does what, and two turkeys don't make an eagle, and you end up with two basket cases. This is the first time where we've said we're going to take this place over and sort it out. So by having the organisational freedom to do what Andrew did and a bung of about 300 million, he's sorted it out. And Peter Homer will do the same thing with Sherwood Forest.
I very much hope he does. The just so that people know about the bung, the bung is actually capital funding to rebuild the Heatherwood site, which is the elective site.
It's a terrible.
The Wexham. It is terrible. It needs to be redeveloped. The Wexham Park site, the revenue costs of running that as good are lower than they were when it was bad.
I'm not the least bit surprised.
No, but I mean,
it's a takeover. My point is, Mike, it's a takeover.
Yes, it is a takeover.
It's the mechanisms that have allowed people to do the job properly rather than fudge it with a merge.
Yeah. And that's fine. And we've heard about chains and foundation groups, etc. The only thing I would say is, if you're going to have a takeover, make sure it's a takeover by somewhere that is already good or outstanding.
Yeah. Okay. Right. What do we all think? Has anybody got any questions for Mike? Yes, ma'am. Tell us who you are so we can report you to your employer, and feel free to ask any questions you want.
My name is Lilley Wright. I now work independently. I used to be part of Mike's diagnostics cancer team for about 14 years. And one of my roles is as a specialist advisor for CQC, and I inspect...
So you're a plant, really?
No, I'm not.
I had no idea that Leslie was coming this evening.
One of my roles is to support inspecting diagnostics in outpatients. And one of my criticisms of the CQC, and I think there are some valuable things, is, Mike, you've lumped diagnostic imaging and outpatients together, and you can have an outstanding diagnostic department and a very poor outpatient department will bring the whole thing down, and vice versa. What's the opportunities to actually separate these two from each other, because both are equally important, but both do very different things?
Leslie, you are 100% right. We added imaging in after we started, and we put it with outpatients, and we shouldn't have done. It should have been a separate core service, and it will be from the next phase onwards. You've got my word on that. But it doesn't make sense if you've got, and for just the reasons that you've outlined, if you've got something that's very good, something that's not at all good, you end up saying it requires improvement. So that is an error that we've made, and we can correct it. We've always been clear.
Will you apologise to all the hospitals that you criticise?
No,
in this way?
No, because actually, if you read the reports in detail, we actually say the bits about the diagnostics and the outpatients, but it takes disentangling, and that isn't satisfactory. So
is it? Well, I mean, that's interesting, isn't it? You see, you've run a nest here, because quite often hospitals are in the problems they're in because of the local health economy and the interrelated structures between hospitals, not least of which is social services, where hospitals get bunged up because they can't discharge. I know you'll say, well, some hospitals manage to do it, but I don't think it's much of an answer. I mean, you do have to look, don't you, across the whole of the landscape if you're going to take a view.
Yeah. And that's where I think we are seeing new models of care. We are seeing some trusts that are managing social care services. We're seeing some trusts, David Dalton's trust, Salford Royal, runs a general practice that on its own provides the medical care to something like 80% of the care.
Do you inspect that, or does Inspector Field inspect that?
We inspected it as part of our Salford Royal inspection, but we made sure we took with us people from Steve Field's team.
More people, bigger bus.
Well, it's an. They would
More
be,
money.
They would no. I mean, they would have been inspected as a general practice anyway.
If Edwards Deming was sitting here tonight, what would you say to him? Would you say you're wrong?
I'd say come on one of our inspections and actually see what it is.
Well, he's turning in his grave at the thought of it.
Yes. Well,
what are you going to do about the money now? Because quite rightly, the government has finally decided that 200 million quid is more than enough, and you've now got to sort yourself out with some money. I can't see there's much in the way of income generation for you. What are you doing? What's the? I've looked at the consultation thing. It just the best idea that David Beamoth has got about sorting the money out is to charge everybody a shed load more.
There are two completely separate issues there. One is a government commitment that over time we should not have grant in aid from the Department of Health, but we should charge all our expenses as fees to whether it's care homes, hospitals or general practices. That is a government decision. There is the second thing, which is we have got to tighten our belts. That is the same.
But what is your
as hospitals are doing?
Well,
we've got to do more. We've got to do it better, and we've got to do it for less.
But I mean, can you? I mean, if they're talking about a huge hike in. I mean, I know it's not your specialist area, but you are on the board, so you can speak for the organisation. It's a huge hike now in care home, or they're proposing a huge hike in care home registration inspection fees, and most of them are trading at the margins. I mean, you can see them being tipped over into bankruptcy.
I don't actually think that that will make the difference between tipping them over into bankruptcy, but I do think we have a problem with funding of social care in this country. I don't think anybody denies that.
But we're not going to give social care more money to give it to you to inspect them. That's not the idea.
But we have got to find ways of making sure that our ever more older population get the care that they need. And that care is not sitting in acute hospitals. It is being able to be cared for at home wherever possible, and in care homes when they need to be in care homes. I don't think we have a proper good funding solution.
I don't want to get off on care homes. I know it's not your specialist topic, and a lot of people want to ask you something. But I read a really fascinating statistic the other day that said 50% of people who are taken into hospital with a blue light over 75 come from care homes. And the argument was that where people go into a care home, over time they're living longer, their acuity falls off, and actually they need nursing care, which care homes can't provide because that's not what they're licensed to do, or indeed funded to do. And one wonders really whether or not we need a radical rejigging of care homes to reflect the fact that people are a lot older and need a lot more help.
And going back to my example of Salford Royal, that's where one of the things that I don't think we've got right in this country is the medical support for care homes, but the GP practice that Salford Royal manages, they specialise in that. And incidentally, that is very similar to what happens in the Netherlands. And that
Birdsong. You know about Birdsong?
I don't know about it in detail, but I do know of it. And what I do know is that actually reduces admissions to acute hospitals, so it's good for patients.
Well, on the Academy,
on
the Academy of Fabulous Stuff,
Yeah.
which is the website that we run, which is dedicated to excellence and good practice and innovation,
Yeah.
which is probably not something that you've ever looked at. We have got some, Terry. We've got some very good examples. Where was it in Nottingham? Was it? Oh no, it was Liverpool, wasn't it?
Aintree with their with Airedale with their telemedicine. Aintree have advanced enhanced
what Aintree
pathways.
were doing, this is important because it doesn't come out in inspection, but what Aintree were doing is they were saying, right, somebody's medically fit to discharge, we will discharge them and we will sort out the support when they get home. Two things happened as a result of that. Higher sense of urgency about having to do it, and people's acuity in their own home is different.
What makes you think that our reports don't mention
Well,
these
because
things?
I looked
if
at
you
it, because
look
I
at
looked
our
at
reports,
I looked at it and it's
I
not
know,
there.
I think you'll find it is actually.
What, that
I
initiative?
think it is. I can't be. We can all look it up. Somebody Google
Right,
it straight
yes,
away.
but not now.
Because we always report on outstanding practice. And in fact, I'm going to make you an offer at this point.
Right.
Why don't we get together with our examples of outstanding practice and make sure that they do come to your Academy of Fabulous Staff?
Absolutely, you heard it here first. Round of applause, first sensible thing. We would love to do that because one of the reasons that John and I put the money in and Terry joined us really was because I got so sick of your lot stomping around telling us that nothing was any good, and I knew that it was.
Well, our reports do reveal what is good, and we then praise it, and that is part of this whole program that I am running. Is about showing what is outstanding.
But you're
as
so,
well as about what's
so
inadequate.
buried in inspection and finding things that are wrong, in special measures. I mean, how many? We had a fantastic evening here. Some of you would have been here when Keith McNeil was here at Adbrooks, right? Now, and I wrote a piece of who is the most dangerous person in the NHS. I don't know if you saw it. Keith
I think you can rest assured that I was very proud.
It went across your desk. We did say who was there, because Keith McNeil, for those of you who don't know, is the chief executive of Adbrooks. He said the hospital was dangerous. Keith got the and left. But the thing about Keith is he's ex-Australian SAS, right? And so I couldn't resist the urge to write a piece that said who was the most dangerous person in the NHS, him, the inspector, or the ex-SAS guy. And I concluded, after careful thought, that you were.
And so that is why Cambridge is now a much safer hospital than it was.
It wasn't dangerous. You can't tell.
Yes,
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 how many
read the report.
I did.
There were really bad things going on.
There were issues around staffing in ITU.
Yes, that is true.
And Keith was doing it entirely differently. And look at his outcomes. You looked at his inputs.
He denied that the facts about the numbers on his ICU he didn't even know. And we had to take a team and actually demonstrate to him what he didn't know about his own staff. And that was not only on the intensive care unit. And I will say this, I think that is now a better hospital. It's a better hospital and it's been better managed, and I think the people of Cambridge, Roland Singer is in there, and it's running a better show. And we can demonstrate that.
Right, what have we got, Terry? Yes, hang on, I'll come to you in a minute, Michael. Yeah. Oh, well, gentleman at the back, the beard. Far away.
Quick question. Based on the conversation so far, you've talked about federated model or hospital chain. There's a lot of your phrase here. You saying around whether it's inspection leading to that better model. What do you think that the naked taking over of a hospital would lead to better improvement, or do you think the new federated or hospital chain model would lead to better improvement overall?
I think if a hospital that is faring badly is taken over by a hospital that has got good leadership and really know what good looks like and have got strength in depth, then that can lead to quite rapid improvement in the quality of care given in the hospital that had been faring badly. I've shown you the example, the best example we've got, and I have no doubt at all that the population there are getting a better deal. The staff are much happier, and the staff, as a matter of interest, in terms of whether they would recommend the hospital to friends or relatives, that's gone up from only 25% to 69% in only a year. So it's not just me saying it is them saying it. And so I think there are cases where takeovers but given those criteria that I just set out, where it can be very successful.
You look puzzled, right? You want to come back?
Slightly, yeah. I mean, I'm from Bromley CCG. We have a local health economy where there were 3 acute trusts that were merged several years ago to
Yep.
form a super acute trust that subsequently was 4 in each stream.
But wouldn't you say that that really rather supports my my argument in that mergers don't work, but takeovers do?
And hence the
Yes, and takeovers are very difficult because depends what kind of a hospital you've got. If you've got FTs, it requires a regulation through Parliament and all the rest of it. It was just very fortunate that at Wexham they weren't an FT. They were
Yes,
just,
they were.
Were Wexham?
They absolutely
okay,
were.
Okay, let me get the other way around. It's one. Which way around is? There's one of the ways round if one is and one isn't, or something.
But in that case,
quite
both Frimley and Wexham were foundation trusts, and but Wexham knew that they needed different leadership.
But
and
it requires
a
change to the constitution, which is a regulation in Parliament to do it, and that's not impossible to do. But it has previously been the impediment to naked takeovers, whereas before you get. I mean, look at Barts, for example, how that's merged and got itself into all kinds of problems. That wasn't a good move, was it, with Barts to merge?
I think at the time it may have looked a sensible thing to do. I think our project hadn't come into effect then. If we had gone and looked at what the quality of care was in the individual hospitals, we might have been able to say, actually, that's a foolish thing to be doing, because bringing together a number of hospitals, none of which is delivering at a good or outstanding level, would not be
Do you
a
think,
sensible thing.
it's quite an interesting point. I mean, do you think you should have more power to direct the future of organisations? I mean, let's take that, not Colchester, the other one that you mentioned,
Medway.
down in Medway. I mean, Medway have struggled, haven't they? I mean,
yes,
I've been there. They've worked hard, but they've got a mess on their hands. They find it hugely difficult to recruit. The money doesn't add up in the local health economy. They've got the local CCGs that are at war with each other. I mean, you really do need to. Somebody needs to go down there and bang heads together. Now, we don't have strategic health authorities, and the divining strategic hand of a health authority, the hand of a strategic health authority is missing to make things happen. Do you think you could fill that gap?
I don't think we can on our own, but I think the combination of CQC and NHS improvement working together, and sometimes with NHS England and the CCGs, and I'm delighted to say that we are developing a very good working relationship with Jim Mackey and his team, and I think that will...
Well, they've rebranded, haven't they? They've stopped being Monitor, and now they're all lovely and cuddly, and we're here to help.
Well, yeah, they've also got a job to do as a regulator as well as...
Well, I mean, Ed Smith talks about the difficulty of combining those two. There's a great joke, isn't there? Of course, I love you in the morning, the check's in the post, and I'm here for Monitor to help you. They're the 3 fundamental lies. Anyway, Michael, you had a question. Could you please be nice, because it's our sponsor speaking. All right.
I'll be nice because it's Michael, and I've known him a very long time, but I have no idea what questions.
Just start by saying, what a terrific question.
Why doesn't he shut up? Going back to the theme of things they just didn't know.
Yeah.
Can you foresee the time, or anticipate the time, when the regulatory function will include looking at the use of information and the use of information systems within these organisations to maintain and improve quality?
It's a good question. It's the better use of data, isn't it? We've got a lot more now.
Doesn't sound like it.
Up to a point we already do, but I think we can do more on that. And there is huge variation in what the data systems are in different trusts and how well they're using them. And you probably know that far better than I do, to be honest. But I think that is part of our health inspection programme, but only one part of it. But I think what I really want to get to is a point where we have this shared view of quality. In other words, we agree the framework. We agree it at national level with people like Jim Mackey at NHS Improvement and Simon Stevens, and we say, I would base it on our safe, effective, caring, responsive, well-led, and now add into that efficiency as well. Make those 6 broad questions under which there are a lot of other questions. And actually, use of data can come in under those sub-questions within that. But if all the trusts are really looking at it themselves in that way, they will have a better view of their own quality. They will be able to use it. Go back to my example of Frimley. They have adopted our framework, and they do it at a much more granular level than we ask for it. So Tim Ho, the medical director, will say, I want to know about respiratory medicine, gastroenterology, cardiology, not just about general medicine. So that's fine. Incidentally, they are now also using that same approach for improvement. So when Prem, the wonderful A&E consultant from Frimley, went into Wexham Park, he talked to the consultants at Wexham Park and he said, look, work with me on this. But he had 5 of them that he talked to, and he said, why don't you lead on improving safety, you lead on improving effectiveness, you lead on caring, you lead on responsiveness, and you lead on well-led. And they did it, and they turned it round. And so the same framework that we are using for assessment at CQC can be used by trust for assessment, but it can also then be used for improvement.
Wouldn't you, I think it's a good point, I mean, wouldn't you oblige trust to use that template?
I hope we'll get there without making it an obligation.
I mean, wouldn't commissioners, if you're a local commissioner, like our friend here, you're with the CCG, wouldn't you say, we will only put contracts with hospitals that use these templates?
One of the questions we asked we're consulting on our next strategy because we're coming to the end of our first round, and one of the questions we asked there is, are we right to go for this shared view of quality? And so everybody can respond to us on that.
I suppose it doesn't really matter what the shared view is, as long as it is a shared view.
I largely agree with that.
You have to do something. You can't carry on the way you are because we're going to give our last shilling to you to give to the bus company.
That of course is not true. But having said that, I do believe having got this really good baseline picture of trust across the country, we will be able to have a much more tailored and targeted approach in the future.
But you've got to do something to cut your costs.
So will I need to go and look at the whole of Frimley Park next time round? No. I probably want to go and look at that one bit that's had a yellow on the grid before.
But that defeats all your arguments,
no,
because you're saying that we turn up unexpected, and keep people on their toes. Now you're saying we don't have to be on your toes because we're not going to come.
No. I'm not saying we're not going to come. What I'm saying is we will do. This is our proposal anyway for discussion. That we will gather all the information together internally, the national data sets, the data from the hospital, what we know from the last inspection, what we've heard from our local inspectors who liaise with the hospitals. We will formally look through that, and we might say, well, what we need to do this time round is go and look at 2 of their core services, not 8, and we also want to go and talk to the leadership and make sure that they are still on their toes.
Who else does inspection? Denmark have just knocked it on the head, haven't they?
They've changed it. I don't know the details of what they've done to change it, but I think it's interesting that quite a lot of people internationally are now saying to us, you wouldn't like to come and do it here. Now, at the moment, I've got a job to do in this country, so but
tell them to ring me. Sharon Lamont has a question. Dr. Sharon Lamont.
NHS England. I feel I do have to stick up for the CQC here.
Well, of course you will. You work for NHS England.
Well, no.
That doesn't necessarily mean that we're, but thank you nonetheless.
I think you have a rather simplistic view of inspection, Roy, and that always comes across in your blogs. And I think it really.
What time did you train back to the
I think it's absolutely essential to have inspection as part of the quality improvement process, and you're absolutely right, it's one element of it, and you're also right, you always do quote the positive sides of your inspection. I mean, you will know, Roy, that I used to lead in teams to look for MRSA and CDIS. I took in teams.
You were the nation's cleaning lady at one stage.
And what a difference that inspection regime made. What a difference that made.
I don't think people knew what good. Have you got a question, or are you just the head of Mike's fan club?
I was going to pull you up on the deeming thing because he talked about beam counters, and I think that actually CQC moved far away from
14 points of management, Deming. I know them by heart. Go on. And what else?
And then the final thing, yes, they are comments, but I know of one, I've got one example, I won't say the name of the trust, but this trust is very successful financially, which is, you know, what we tend to
Which
always
is
look
all
at.
that matters.
Yeah, absolutely.
Nope.
Sadly, it does, that's all that matters for this particular trust.
Yeah.
I'd love CQC to go in and just to see some of the patient failing that goes on, and some of those directorates where actually it's just an accident waiting to happen, and they don't know that because they're not looking. They're not all as good as you were as a chair in your organisation. They don't know about this particular problem in these particular directorates.
My argument with Mike is not that there isn't, you know, quality is not an issue. The issue is turning up on one day and taking a Polaroid is not as good as having organisations properly led. And your well-led function, which is one of your domains that I've looked at being interested in leadership, seems to me doesn't do anything around leadership. It just says on the day we arrived there was a mess.
Let me just tell you about the well-led. I mean, well-led is about the leaders themselves, but it's about whether they've got a vision and a strategy in the organisation, what their governance arrangements are in the organisation. We've seen places that have axed their governance departments to try and save money, and then everything's gone pear-shaped. It's about the culture in the organisation. We put all of that together, and why do we do that? Because the academics in the field, people like Michael West, have actually demonstrated that if you have all those characteristics, that predicts what the future quality will be. He's shown the link between those elements of being well led and both patient mortality and patient experience. So that's why we've chosen to look at well led, and I think it is a very, very important component of our inspections.
What have we got?
Well, we've got a question from...
Is it St David's Day, gentlemen, here? Is that Macmillan you're wearing, or is it St David's Day?
It can be both.
Well, which is it?
Or even Marie Curie.
Maybe St David's Day.
Eh?
St David's Day.
It's a day. Well, as it's your day, we'll let you go first.
I was wondering where you think end-of-life care is.
Why I think it's
Particularly
important.
on background.
Why I think it's important. Well, the simple answer is we are all going to die.
Where it is.
Where it is.
Yeah.
Well, first thing is we have deliberately made end-of-life care one of our core services to look at, and partly that is because work I did in my previous job showed that hospitals were not good at this at all. So on average, they vary a lot. So we set up a voices survey of bereaved relatives, and there were big variations across the country. But also, in terms of where relatives of patients who recently died, their comments on hospitals were much more negative than they were about comments on care homes or comments on dying at home.
Hospices.
And hospices, of course, came out top. So,
but it can be done.
It can be done.
Was it Northumberland? We went to Northumberland and had a look at the care.
I can't possibly comment on Northumberland because their report isn't quite out yet, but you're absolutely right.
I did. Jim Mackey will...
I will comment on the end-of-life care service there and just say you're absolutely right.
Yeah, I think because it is difficult. End-of-life care in a hospital, end-of-life care in a bed in a ward is almost impossible to do properly. And what they've done is they have an end-of-life care ward where they've taken people out of the hurly-burly, stripped everything out, and made it a much more sympathetic.
And they have an integrated team that works in the hospital, working with a team in the community, and if a patient wants to go home to die, the hospital team actually go home with the patient and hand over in the home to the community team. It's an integrated trust, so the Northumbria Trust runs both the hospital service and the community service. It is one of the best examples of integration.
And I don't know if you've been there, but Macclesfield have a fantastic hospital end-of-life care at home service as well, which is worth having a look at. Right, sorry, let's get to some of the text. Some people.
Okay, so this is a question from Roger Klein.
Yes.
And
I hope he's on Periscope. Was he watching?
I hope he is. Hi, Roger, if you are.
This, in fact, his question was text in prior to your very, very generous offer to send your fabulous stuff on fabulous NHS stuff. But his question is, actually, hasn't Berwick said that the CQC can be the engine for spreading best practice? Is there any coincidence with your offer?
Well, he has said.
He has said that.
Last week,
And,
hasn't
well, no, actually he said it today in the HSJ.
Yep,
And,
that's what he's quoting.
And I think a couple of weeks ago, Don Berwick had some more negative comments to make about inspection. He must have been listening to you. But
Me and Don.
but actually, I think that he now does understand what it is we're trying to do, and that this inspection programme is about being one part of a drive for improvement.
There's no question about that, and if it's to mean anything, you've got to find a way of diffusing the best stuff that you find, because at the moment it's buried in all your paperwork. And we will give you that platform to try and rescue your miserable organisation's reputation across the whole of the NHS. Yes, ma'am.
So I'd like to ask you what the CQC can do when you've found problems and nothing happens. And I'm thinking particularly of Southern Healthcare. So you have had criticisms of Southern Healthcare. There have been reports by Veritas and Mazars, and we're not clear what's happening to make people safer in Southern Healthcare.
I think there's a bit of litigation outstanding there as well, isn't there?
With Southern
We
Health,
just need to be mindful of that.
with Southern Health, we
We need to be mindful of the fact that there are still people having bad experiences.
Yes, no, I agree.
No, and when we inspected, I can't remember the exact date of our inspection, we found a number of quite serious problems, and we issued a number of compliance action and warning notices about that. We have more recently we have re-inspected focusing on those areas. I have not yet seen that report, so I can't comment on it.
CQC, your report identified the problems, but you identified them some time ago. You've re-inspected. Sarah Ryan is very vocal on Twitter about her experience with a whole load of agencies, and so I don't have an issue with the CQC inspection, but I want to know what the point of it is if it doesn't result in improvement.
Well, can we deal with it in a wider context?
But if any hospital, let's wind it from Southern Health. But there are, unfortunately, a lot of hospitals that we have rated as requires improvement overall, where they have a number of problems throughout, and some, as you know, we put into special measures because they're inadequate. I think what we now need, and this is working particularly with NHS improvement, is to say, actually, what is our approach to helping those trusts improve? Because not all trusts have the capability to do that. And now, I think there can be programs that are focused on specific areas, like diagnostics, for example. If that's where the problem lies, let's get a team that can go in and do that. And I think the emergency teams have been quite good at supporting A&E departments. So it may be focused on a service. It may be focused on safety, and saying what is it we need to do for safety. Because in safety, there are two main things. There have been hospitals that haven't had enough staff, but there have also been a lot of hospitals that really just haven't got the safety culture embedded in that hospital. They're not doing their incident reporting right, they're not learning from incidents, they're not checking their resuscitation boxes, they're not checking their massive obstetric hemorrhage boxes, etc. Now, those are fairly fundamental things and basic things. We are finding that. They have their fire doors blocked. There are things like that. Now, very soon, I hope that we will be able to put together multiple examples of where actually following our inspections, those things have been put right very quickly. Now, there are some places where things aren't put right, and that's where we will be talking to NHS improvement and saying, really, actually, something's got to be done here.
But, just to recontextualise that question, because it's something that you and I touched on earlier on. So you go in and you find something wrong. You don't really have mechanisms to put it right. You can say, you could be as draconian as you like, but you're not going to close down a hospital. What's missing, I mean, apart from the fact inspection only takes place on one day and so it's irrelevant the next day, trying to fix something, you don't have the staff, and neither could you, to go in and fix it.
But that's why and it's actually right that these...
But you can't leave it to Jim, can you?
Well, actually, yes, on the improvement side, but the reason why we are not an improvement agency is that we've got to go back and reassess and really take an independent look and say, is this any
Well,
better?
David talks about marking his own homework.
Well,
But surely, if your role in life is to improve the standard of healthcare for the nation,
is to encourage improvement, yes.
well,
We do encourage improvement, and we've seen improvement. haven't
we
in a lot
got
of
the
places.
audience are waking up now, and it's 7:20. Right, I'll go to the blonde lady at the back, and then I'll come down to Sebastian, and then to you.
I'm wondering, I think you're both right, and I think it's not an either or. And so my view would be, and some of the trusts we've worked with, is those that understand the framework of what's good quality improvement do it on a daily basis. Some of them have even gone as far as having their own internal peer review teams that actually conduct a similar type of approach within their own organisation. Some of them share with other organisations. And I think we aren't in a place where we can have one or the other, but maybe it's a journey. And I think if you look at what Don Berwick says, he would say we need to move to a position where the sort of things that you're saying, Roy, is that trusts, there are no surprises, that they've got that teams that operate across the whole of their organisation, and you could perhaps use the framework that you're talking about, like, that they assess each other or they assess each other's departments on that, and there are no surprises, then you won't need inspection. But we're not quite there yet, and I think the answer's in the middle.
But do you think, I'll come to it, but do you think that all the time we have inspection, that we won't change gear and move to the what I would regard as the preferable situation where people sort themselves out?
Well, I think, and also you talk a lot about internationally, I think there is a variation. So there are a number of places that do have a similar type of process, but they're always aiming to meet the standards. So the difference between CQC are regulators, so they're quality assurance, standard yes, no. You know, quality improvement is always striving to be better. And I think giving people the tools in which to do that, and we are seeing, you know, there are some organisations that actually say, and I've heard them say, I can't remember the trust, but there's a group of paediatricians that's leading this kind of approach, who's saying, I don't want to wait for the CQC inspection, I want to know this afternoon.
Well, that's what we're supposed to be.
That's what everybody should be
Yeah.
doing. And if we can do ourselves out of a job, how happy I would be.
Absolutely.
You know, so we can agree on that one, but we are a long way off that at the moment, because a lot of people don't know what their quality is like, and they haven't sorted it.
Okay, Sebastian.
Sebastian, you're a paediatrician. Thank you.
Is it here?
So I'm just interested in what do you think is going to make the difference? Because we do know what good looks like to some extent. We've got IHI, family stage stuff. We've got lots of things that shows what good looks like, but we're stuck in these systems. And looking at an organisation is a big problem when social care is in trouble, the organisation hasn't got money, you can't get workforce, there's low morale, and this is increasingly across the NHS now. So chief execs may have a good vision, but they can't implement it because of firefighting. NHS Improvement's coming along to work in partnership with you. There's not a lot of quality in there. Yeah. NHS IQ's gone, safety may not go in, the board is all TDA monitor. I'm just wondering...
Yeah, the board is all retreads, isn't it? That's a good question, isn't it?
I mean, I think what we're also seeing is the importance of leadership. I think we need to have far more people spending time either with David Dalton or with Andrew Morris or whoever, really seeing what good leadership is and how to run a good trust. Because you say we know what the good looks like. Actually, an awful lot of people don't.
But it's our job to show them, isn't it?
It is our job to show them. And so what we can do is identify where leadership is coming out really well. And actually, what would I do? I would have that as part of an academy or whatever, based around Frimley or based around Salford, so that people would come and see how it's done.
Let's talk briefly about the Leadership Academy, which I know is not entirely within your purview. But if you look at anybody been to the Leadership Academy, done a course here? Mm-hmm. Quite a few of you. I mean, it strikes me, let me phrase this, I'm not against the Leadership Academy, absolutely not, but I do think that they're very broadly spread. They run a lot of courses for people who, actually, okay, it's good for them to know about leadership, but probably never will be leaders. Do we not need a Sandhurst type of organisation?
Well, I think we need several smaller Sandhursts, and what I would personally do.
Why several small?
Well, because
Why
I
not
think
a
we need them
national-
around. Because I actually think we need it around the country, and I think you need practical experience. I think people going and
Well, the
spending.
British Army do it in one place called Sandhurst.
Yes. How many people are in the British Army?
80,000.
Yes. How many people in the NHS?
1.4 million.
So, and for once I agree with your numbers too. I mean, you know, that's quite remarkable.
It's only having a laugh.
You know, I think what I would do is I would build leadership experience around places that are doing it really well, so that people. Secondments, yeah.
We like secondments. Right. Where are we?
We like
right.
secondments at CQC.
Okay. Now look, I have to finish at 12:30. So, can you do 3 questions on the
Yeah,
bounce?
yeah,
And
absolutely.
can you make it very brief? Yes.
Yeah.
Okay, well, I'm not born and bred NHS. I've only been NHS for 8 years, which actually I still feel like I'm new to a great extent. And the thing that really surprises me, you know, with the CQC going round, is that suddenly a hospital becomes about a hospital after a visit, which obviously, you know, these things, like you're actually saying, it's one day, one point in time. What I don't understand is that hospitals don't actually have the parameters that you actually work with to actually audit them. You know, being looked at on a 6-monthly annual basis anyway, so they actually know where they are, you know, at any given time. When I came into looking after a small section of my trust, which was health, I took over from someone and I thought, right, I need somebody to actually tell me where I am at the moment, because I know where I want to actually go. And we had an internal audit. That, for some strange reason, went straight up to the board. I got all sorts of exciting sort of emails back. Nothing had actually changed. I just sort of stepped in there and just wanted to know where I was and where I needed to actually get to. Whereas what I actually wanted was somebody to come in and tell me, you know, sort of the areas of improvement.
What good looks
do
like.
that.
Yeah.
Rather
Okay.
than
Don't
becoming
forgive me. I'm not cutting you short, but I'm just against time. Okay. But I mean, the Strategic Health Authority is used to do that. Right. You make a note. Yeah, right. Yes, sir.
Jeff Siegel, the funding pressures that are coming, and I see you from these due to posted deficit, do you expect that to have a negative impact on future inspections, given that it sounds like inspections aren't going on?
Okay, funding, yeah. Yep. Having a deficit is like a fashion accessory these days. Everybody has to have one. Yes.
I can be really quick. I agree with both sides of this points that have been made. I prefer an edge on yours, Roy, in terms of proactivity and getting stuff done.
Good man.
But I think you two can do that. I really genuinely do. For me, the biggest point is leadership. So leadership isn't so much about education tools, it's about engaging people on the ground floor to be energised and enthusiastic.
Yeah.
And they've got the ideas. It's not the leaders that got the ideas, it's the people on the ground
Well,
floor.
you probably find it as
Yeah.
well. You visit a hospital and you find it fizzing with great ideas.
And there's things that we can do
that
there
disappear.
to capture that.
Exactly. Shane, do you want to?
Very
Excuse me.
briefly.
This is the sponsor. Be nice.
Be nice. Okay.
I'm Shane, I'm CEO of MAXIMS. I worry about the CEOs of this country. The examples you've given of greatness have got longevity of leadership. And I'm seeing the longevity of CEOs, the average tenure dropping from 27 months. And I met a CEO the other day, and they said it was 365 days. Now, is there a lot of new CEOs that have just come in? I think not. But anything we can do to help encourage, and an example of a group of hospitals I used to work with before, CEOs once a year used to move around the hospital for a week, and there was peer support review and all sorts of things blended into that. And I know the NHS is big, we've got 165 acutes, but could we, in our little smaller Sandhursts, perhaps encourage some more peer review support and networking?
Okay.
There you go. Can you do that in 90 seconds?
Yes, no problem. You talk about things suddenly going wrong. I don't suppose that actually the problems do start overnight. It suddenly gets recognised. I think that our shared view of quality, our framework, will help places to do that audit that you did when you started off.
I am attracted to the template idea.
Yeah, and so if we can sell that widely and get everybody engaged in it, I think it will make life a whole lot better.
Or oblige it. Just oblige it. Go to the commissioners and say, don't buy anything from hospitals who don't use this template.
And we may well get to that point.
Yeah.
But let's get my belief is that if we get people really engaged to begin with and saying it's a good idea, then if we do need to mandate it, we will, but it may or may not be necessary. Funding issues, let me just say, the funding is very, very tight. I'm the first to acknowledge that. I think what we're also seeing is that running a hospital well is less expensive than running it badly. And you don't have to believe me on that. Anita Charlesworth from the Health Foundation, worryingly, the analysis also found that poor quality of care was associated with larger deficits. Acute and specialist trusts found to be inadequate by the CQC were more likely to be in deficit than other trusts. So and what we've shown with the Wexham Park example is you can turn it round and it's actually then costs less to run than it did before. Leadership and engagement, absolutely. It's just that's the most critical element we've got to get right. Longevity of CEOs. I think we do have to recognise how difficult the CEO role is. I'm certainly not wanting to do anything to undermine that. I absolutely know that they need support. I think what we've shown with special measures, whereas for 65 of the 68 years of the NHS, our basic policy was if something was failing, you just get rid of the CEO. I think what the special measures regime is about is saying it needs external support.
Well, I'm just going to say, do you think you perhaps need to redefine your approach around leadership to say that these trusts are not necessarily badly led, but they are led in a way that they could be led better, particularly if you get, for example, an interim chief executive in who's had his arm up his back to bring the place back into balance. Do you think you need to attenuate your approach to leadership?
Well, I think we need to say it as it is. So we need to say what we see about the leadership, what we see about the vision and strategy, the culture, the governance, all of those other factors. But yes, we do see some very good interims who do help to turn things around. And we need to encourage the next generation of managers and support them to become good leaders.
Quite agree. Listen, we're up against the buffers of time. Might be just before we finish up, we've got a little gift for you here that the regulars will know about. It's a bottle of scotch that we like to give to our guests to say thank you. It's a very special bottle of scotch. It's actually Welsh whiskey.
Right, fair enough.
Which is Penderyn, which is the world's finest whiskey.
Very wonderful.
A little tiny splash of water, you'll love it. But even better is that it's just above the limit where you have to declare it as a gift. And we just love the idea that I've had a present from Roy Lilley. Mike, you've been great guests. Thank you very much.